of us, including myself, feel that if we do a good bipolar hemiarthroplasty, we are done. Patient will go to the grave with the implant that I have put in, and there should not be a problem unless, of course, they have a periprosthetic fracture, which Sunil just alluded to. Now, I'm going to share with you a few different methods when the hemiarthroplasty behaves literally like a damsel in distress. And then it's not very easy to sort it out, but there's no other option. And the bipolar done by us is going to come back to us. And then that is the time when we become arthroplasty surgeons and trauma surgeons rolled into one. So for all you people sitting out here, whoever does either one of the two, both of these principles have to be respected. So this is my first group of two cases, which Dr. Pangade also loves to allude to, penny wise, pound foolish, which is saving money on the quality of the hemiarthroplasty that is used. This can happen. The bipolar can decouple depending on what quality of implant you have used. This was a gentleman, sort of a lady, who came 4 years post-operative with this problem. She was treated elsewhere with a locally manufactured component. Now, when this comes to you, you have no real option but to give her the full Monty. So you have to be aware of how to do an ETO to get that defective stem out, because the mechanism is not functioning, and then replace it with a distal fixing stem with a 6-month post-op picture, which was shown here. The other situation is this. This is a little more common. This lady was 73-year-old when I first saw her. She was 5 years post-op with hip and thigh pain since about 6 months. And the plan was to convert her to a total hip, because the assumption was that she was probably having some acetabular erosion. I did take a conventional direct lateral approach. The stem was loose at the proximal end, but this was what I found. So the proximal part of the stem just came into my hand after I had removed the cement at the level of the calcar. Now, I'm stuck now with a well-fixed distally cemented piece, which I have no access, no way to get to unless I do an ETO. Now, initially the X-ray did not show me any fractures of the stem there, but if you go back, there's a little bit of a hint that there might have been something which I could not pick up, but as I say, hindsight is a lovely teacher. So again, to do a ETO now, this time through a direct lateral approach, so I had to fashion one on table, and luckily was able to get away with it using a distal fixing stem, which I had kept as a standby because I felt it was something I may need a stem revision for. So, this is a case which I have borrowed from my friend Dr. Mahale. This was a cemented bipolar done conventional, Exeter bipolar, 88-year-old lady. She goes home walking, has a stumble at home, and comes back with a dislocated bipolar hip. Now the first thought is, okay, we'll try and do a close reduction. Would everybody agree? Who said that? Okay, Harshad, you obviously have burnt your fingers. Okay, so we did, okay, in our naivety, and this is exactly what happened. So the stem started walking out. Okay, so this was a well-cemented Exeter stem a week or 10 days post-operative, and doing a close reduction, the stem started walking out. Now this is a known problem that can happen in this type of cemented stem designs. So you have to be aware that this can be an issue. Well, this was what we were faced on table. The initial plan was to retain the stem and do an acetabular constraint liner, but we had to bail out and wait for the cement and cement revision stem to be available before we could salvage this case. So another thing which you have to be aware of, that when you're doing a close reduction for a cemented bipolar of this type of stem design, it can walk out. And I'm talking about the Exeter here. I'm not sure how the Indian copies will behave, but be aware. Things can go pear-shaped. So 2 cases of a similar problem. So this is a lady who was 74-year-old when she presented. She had an intracap neck femur. About 4 years post-surgery, she developed acute onset pain with inability to stand or move. She did say that she had a 3-week history of mild pain prior to this episode happening. There was clearly no history of any fresh trauma. This was salvaged. We are using an ETO to remove the stem, and for the acetabular side, I did have cages available because we do not know how much defect to be available. So, but we got away with a rim fit cup and a medial hernia mesh with bone graft from the Tata Memorial Hospital. At 5 years, she did well. The stems, the ETO healed up well, and at 10 years, she continues to walk, but medical conditions are a big problem here. So the ETO did heal up very well at 5 years, and the bone graft in the acetabulum consolidated well. Another case, a 50-year-old female had a neck femur in 2019, had an uncemented hemiarthroplasty, was immediately mobilized somewhere outside the city. 12 months to 5 years, this is her progression of her X-ray as it worsened. She presented to me at this juncture. This is her walking pattern with pain, obviously. These are detailed pre-op workup because failure is so early, you have to make sure there's no infection here. We did a USG guided hip aspiration, it was negative. A CT angiography to rule out any vascular surprises, and a pelvis CT to see what bone stock was available. A direct lateral approach, this time did an ETO through that, using a distal fixing stem and impaction grafting with the pinnacle gription cup. This is her walking at 5 months post-op, and this is a year post-op now, comfortable with no pain. So these surprises are not uncommon and will come to you occasionally in practice, so you have to be prepared for it. The last one in my group is instability. The 2 cases where the bipolar dislocates in patients who have got multiple comorbidities. 4 months post-operative, this one, no history of a repeat fall, treated her with the addition of a cup with a constrained liner. Another 88-year-old lady where somebody did a coxofemoral bypass, but dislocated again with very poor social input. Now these patients with poor social input are important because they cannot follow instructions. So they really are at the mercy of whatever is available. Treatment options here also, we had to do a cemented, we cemented in a constrained liner because the uncemented cup was just not getting a good hold. Now dual mobility hip replacement is something I have not put in this session because it's something which people are using without a clear indication. But my personal take is that it is something which has to be utilized for the right patient. There are multiple studies which show that the dual mobilities are a bit more stable than a conventional bipolar in groups of patients which have got problems with perception or with neuromuscular disorders or cognitive dysfunction. So these are 2 cases which I did a dual mobility total hip as a first option. They were ideally candidates for a bipolar hemiarthroplasty, but other factors preluded that. So these are the types of dual mobility options available today to us, and everybody should be aware of that. So my personal take is for any patient with an intracapsular neck femur in which you are planning a replacement, please take a detailed history of neuromuscular issues, cognitive dysfunction, and prefer to go for a dual mobility rather than facing them dislocated and then going for constrained liners. I leave you with this thought. Do you think for an 80-year-old patient, a dual mobility should be the first option rather than put them through a bipolar? It is a hornet's nest. I am stirring it. Think about it while we go on to the Q&A session. Thank you very much.